As you can see, I don't have any research funding, honoraria, consultant fees, stock or equity, or speaker bureau fees. And so it's important for all the speakers really to reveal to participants whether they might be influenced by any outside sources. And I've studiously avoided any of those influences. So hopefully you'll get an unbiased view of what interventional psychiatry at the Phoenix VA is like. And so I'm back to my top slide where I'll uh, talk to you a bit about where interventional psychiatry fits in the treatment plan for many patients. I'd like to start by just talking a bit about what psychiatry itself is. So, psychiatry is treatment of cognitive and emotional and behavioral disorders. And we tend to use a few different treatments that are probably pretty well known to you. One of them is talk therapy, and the talk therapies can include things like cognitive behavioral therapy, maybe some of the therapy that you're used to seeing in movies and in popular media, like psychoanalytic therapy, or more commonly, psychodynamic therapy, where you sit individually with a therapist and talk about things in your life that maybe happened in childhood, are happening now, and that affect the way that you view your hopefulness in your future. So talk therapy is one of the tools that we use to help people deal with cognitive and emotional and behavioral disorders. Another method that we might employ would be medication. Again, that's very familiar to many people, and it includes things like common medications like Prozac or Haldol, lithium. And finally, something that is going to be the focus of today's conference are psychosocial treatments. And that's a wide range of different treatments in areas that we might employ to help people with their lives. It includes things like housing and transportation, social contacts, expanding your social circle, for example, access to nutrition, financial independence, even job placement. And so traditional psychiatry employs uh, professionals from many different disciplines, psychiatrists who might help you with your medications, or nurse practitioners or physician assistants who might help you with your medications, psychologists and social workers who may help you with the talk therapy. And then for the psychosocial assessments are social workers and case managers. Most often, the treatments that are delivered by those professionals and received by patients are very successful in helping people with things like depression, anxiety, schizophrenia, bipolar disorder, substance use disorders, and so forth. But there are times where those treatments, for one reason or another, just are not terribly effective for a particular patient. And in those circumstances, a patient may be referred from the more conventional psychiatric treatments to something called interventional psychiatry. Interventional psychiatry can be thought of, I think, most easily as medications that are not oral. So, intravenous medications or intranasal medications would be common, or treatments that are delivered with machines. And some of those machines use electricity, some of them use magnetism, and there are a wide range of different treatments that we might employ. Just to give you a flavor for different interventional psychiatry treatments, I'll read off to you some of the things that I review with patients about past treatments they may have received. I'm just looking at our chat. um, so those treatments may include things like intravenous ketamine or intranasal ketamine, a little nasal spray that's used to improve people's moods, repetitive transcranial magnetic stimulation, electroconvulsive therapy, which is better known as shock therapy. Now, those are four treatments that are either FDA approved, FDA cleared, or used as an off label version of an FDA approved treatment. So, for example, electroconvulsive therapy has been FDA approved for decades. It's almost 100 years old. Transcranial magnetic stimulation was approved in 2008 by the Food and Drug Administration. It was cleared by them in 2008. Similarly, intranasal ketamine has been approved. Oh, it's been almost 5 years now. And intravenous ketamine is approved for anesthesia. There are some other treatments that are less common, and they include things like vagus nerve stimulators or deep brain stimulation. There are things like, you may have seen them in the back of magazines, little devices that you can hold up to your head called transcranial direct current stimulation. And there are more recent treatments that actually are oral medications uh, and might expand the definition of interventional psychiatry. And that includes things like magic mushrooms or psilocybin, ayahuasca or peyote buttons, even ecstasy. And it also includes things that are a little more mundane and that you may have tried yourself, like bright light therapy. Since the field of interventional psychiatry contains so many different modalities, I had to pick one that I thought would be useful to talk about today. And so we're going to focus on repetitive transcranial magnetic stimulation. And the reason I chose that is because I feel like historically it has an interesting story to tell about how a new treatment might come into being and be useful to patients and psychiatrists who are trying to help them. And I hope that by talking about TMS, you'll understand the pipeline and the process for developing some of the newer things that are coming into vogue. So here we go. I'm going to flip through some of the slides now. When talking about repetitive transcranial magnetic stimulation, I have a few objectives. One is I'm going to discuss the science, how it was discovered, and how transcranial magnetic stimulation devices, some of which you can probably see behind me. I have two different TMS chairs back here, how they were invented. I'm going to talk about what's good and what's bad about TMS, what the benefits might be and the risks that is. And then what might indicate that TMS is a good choice for a patient and what might indicate that it's a bad choice for them. I'll also talk about a typical TMS course. There are some patients who come to the clinic and are not typical in their presentation and in their needs. And so I may talk about them if we have adequate time, or you may have some questions at the end about patients who, for example, might not meet criteria for starting TMS. I'll also talk about how patients come to our clinic at the 32nd Street facility in Phoenix. And I'll talk more broadly about how we hope to expand TMS, but also roll out some other services, specifically electroconvulsive therapy and the ketamine treatments at the Phoenix VA. So this is the science. I find this fascinating because, like many things that are, many treatments that are introduced in medicine, the science was discovered centuries earlier. So the story begins in, well, it was about 200 years ago. In the early 1800s, Michael Faraday is a British scientist who discovered something that was pretty surprising, which is that electricity and magnetism are actually the same force. So anyone who is interested in physics will probably be able to tell you that there is electromagnetism, and there's the weak force and the strong force and gravity. Electromagnetism has an interesting feature in that if you have an electric current, I'm looking at the wires that are delivering power to my computer right now. If you have an electric current traveling through a wire, it actually creates a magnetic field. The converse is also true. If you have a magnet, like a bar magnet, and you move that magnet, if you change the magnetic field, either through movement or the size of the magnetic field, you can induce an electric current in any nearby conductor. So this information sort of led to a formulation of equations by James Clerk Maxwell, a Scottish mathematician, physicist, in the late 1800s, Maxwell's equations. And as far as psychiatry was concerned, we were very busy with Freud and we weren't thinking so much about electromagnetism. So we didn't have much use for Maxwell's equations or for Michael Faraday's discovery until about 1985. So there was an engineer in England. His name is Anthony Barker. You can see a picture of him here. I ran into him at a conference in Vancouver a few years back and snapped this photo. I'm a big fan, so I was pretty excited to be able to have lunch with him and talk about his invention. He took Michael Faraday's discovery and he created a device that was essentially a figure-of-8 coil of wire that he ran electricity through. And by doing that, he was able to create a magnetic field. Well, this magnetic field that he created, he made sure that it was changing. It would grow and shrink many times per second. And he thought to himself, well, I've invented this device now that creates a changing magnetic field, but what can I do with it? And he was aware, of course, that neurons are electrochemical organs and that when they fire, it's essentially a transmission of an electric signal using chemistry. But he wasn't sure what exactly, as an engineer, he wasn't sure exactly how that might help humans. So he took his device, which was not unlike the chair that we use now. You can see there's a picture here of a chair. We have two of these chairs at the 32nd Street Clinic in Phoenix. It's a very comfortable overstuffed chair with armrests. But behind the chair, you can see that there's a gantry and there's a bit of a halo, a half halo there. And there's an electric coil embedded inside of that device that moves and is placed on a patient's head to deliver the changing magnetic field. Well, back in 1985, Anthony Barker didn't know what to do with his device. And so he thought, well, I'll take it to London. So he hopped on the train and went down to London to the neurosurgical and neurology hospital. And he dragged his device inside the hospital and he met with some doctors and he said, hey, I have this device that can create a changing magnetic field. And I know that neurons would fire if we put the changing magnetic field near them. Do you have any use for this? And there happened to be a psychiatrist at the hospital that day who said, well, when people get a stroke right about here on their head in the left frontal lobe, they will have depression symptoms. And if we apply the magnetic field to that place, called the left dorsolateral prefrontal cortex, very long word just for the space right here. If we apply a magnetic field to that part of the brain, we might be able to make people happy, even people who haven't had a stroke, just somebody who has depression, spontaneously occurring depression. And so the investigator physicians tried it, and it turns out that they were able to make people happy. So that's sort of the story of how the science was discovered by Michael Faraday, and then there was an inventor, Anthony Barker, and he was motivated enough to bring his machine down to meet some doctors at the hospital. And through that collaboration, they were able to develop a whole new treatment program that's helped millions of people improve their mood. Here are the benefits of TMS. We basically have improved mood, of course. And there's something else. So at this point, since TMS has been around since 2008, we have 15 years of data. We know that people's mood improved, and there's moderate evidence to support the use of TMS in people who have depression. But something new has emerged, which isn't reflected on the slide, but it's worth stating, and that is that TMS is even more effective, strongly effective, for treating people with what I will call cravings. So that includes things like obsessive compulsive disorder, like the craving to do something over and over again, or it's effective for quitting smoking. So people who are craving cigarettes or any tobacco products. You could think about it in other types of cravings too, like eating disorders, for example, or kleptomania, having a craving to take something. And so we may find that in addition to treating people with depression, that there are going to be an expanding array of possibilities for things that, for symptoms that are treatable with TMS. At the same time, it should be noted that there are some things that aren't terribly responsive to TMS. And probably the most common question I get about this is anxiety. So, anxiety is feeling like something bad is going to happen. And for people who have anxiety as part of their depression, yes, they will respond to TMS most likely. But for people who just have anxiety in and of itself without the depression, panic attacks, TMS has not been found to be effective for that. We treat patients in our clinic who have depression. And the reason that we focus on depression is because it's just so common. If we had patients with obsessive compulsive disorder who didn't respond to other treatments, we would treat them. But obsessive compulsive disorder is just more rare than depression. And so, since 10 to 15% of Americans will have a major depressive episode, we're kept pretty busy by patients who have depression. And so that's why I've included the nationally reported effectiveness for major depressive disorder here on this slide. These national results are pretty consistent with what we have found at the Phoenix VA, which is more than half of people who are treated with TMS will have a response to treatment where they get happier. And more than a third will have remission of their depression. Keep in mind that the patients that we're treating are patients who have already tried talk therapies, they have tried medications, often many medications, like a very long list of medications. And for one reason or another, those medications haven't worked. And they're also implementing psychosocial treatments that you would expect would also help improve their mood. And they just haven't responded. So the patients that we meet, well, they are diligent in trying to find a solution and are the types of people who are able to come for repeated visits for TMS. So they're quite reliable. They still have depression. So they have a depression that's very difficult to treat. And yet we still do see a response of more than half of people get happier. Like all treatments, though, transcranial magnetic stimulation has some risks. The changing magnetic field can cause some discomfort, and this is the most common side effect that we've noticed, that on patients' heads, right where the magnet's applied, they'll have discomfort. Sometimes we have to change the direction of the magnet. We might direct it more toward the nose or toward the temple, depending on what's more comfortable for the patient. Sometimes we'll use a topical lidocaine or topical diclofenac, an NSAID. And frequently that will be sufficient for patients who, for one reason or another, are just much more sensitive than the typical patient. After the treatment, patients might also have a headache. And we have found that if the patients simply pre-treat themselves with what they usually take for a headache, ibuprofen or Tylenol, as long as they're not allergic to them, that is usually sufficient for them to not have pain that keeps them from coming in for treatment. Probably the most profound side effect, worrisome side effect, is a seizure. Early on, seizures were occurring in 1.4% of patients, but with advancements in TMS, that has become less frequent. And in fact, it's so infrequent that in the years that I've been providing TMS to patients, I've never had a single patient have a seizure, which is kind of remarkable because seizures are fairly common in the American population. Over 1% of patients have epilepsy. And so, for example, just in my office, when I'm not performing TMS, when I would be treating patients, either with talk therapy or medication, I have had patients in my office have a seizure, but never in the TMS suite. Something that we are particularly concerned about, though, is having safety plans in place. And so we do have a protocol that we follow if someone does have a seizure, and that would include going to the emergency room and having a full evaluation before going home. Acoustic trauma is something that we're concerned about, and that's damage to the ear from the noise of the magnetic field. So we wear earplugs, the patients wear earplugs. I have included a very generous rating of decibels that can cause acoustic trauma, but in fact, there was a more recent study that showed that any decibels above 85 can cause trauma. And so that's why we adhere to using earplugs universally in our clinic. Some patients will get tired after treatment, but that's actually fairly rare. TMS is a treatment where patients drive themselves to the clinic, they have their treatment, and then they drive themselves home. So most people are not tired after their treatment. Some treatments in psychiatry and in medicine generally can cause cognitive effects, difficulty with thinking. What's interesting about TMS is that it's not like electroconvulsive therapy where you might have memory problems. In fact, a meta-analysis or a collection of studies that have been performed showed that patients who receive TMS actually have improvement in their cognition, improvements in their memory and concentration. They're able to react more quickly to questions, and they have more correct responses after they've had TMS. And finally, one side effect that we look for is mania. So mania is, you can think of it as the opposite of depression. So instead of being sad, you might be too happy or so happy and so sped up in terms of thinking and speech that you get annoyed at other people because they can't keep up with you. So it may involve some irritability. It's also connected with not sleeping as much as usual and still feeling great, taking on too many different tasks at once, maybe doing some injudicious things that you later regret. And so it is something that we monitor for, especially with patients who maybe have had mania when they've started medications in the past, to make sure that they're not having that side effect while they're getting TMS. As I mentioned, the reason that we use TMS for essentially all of our patients at the 32nd Street Clinic is major depressive disorder. So I should probably say a few things about what major depressive disorder is. Some people will be fairly familiar with it, and the Van Gogh painting that you see on this slide at Eternity's Gate, I think pictorially summarizes what depression is like. It's low mood. It is the sense that things just aren't as fun as they used to be. So deriving pleasure from activities just isn't as easy when you have depression. It might include things like poor appetite or eating way too much, poor sleep or sleeping way too much, having low energy, maybe suicidal thoughts, feeling worthless or guilty. Now, it doesn't have to be all of these things, but it's most of those things that last at least 2 weeks in duration and that impair functioning, whether it's school or work or socially. And because it impairs people's lives, it's become a disorder. It's deemed a disorder, and it's something that is a focus of treatment. I've mentioned some other indications for using TMS. Obsessive compulsive disorder is one of those things, and smoking cessation. But we're always looking for new uses for the treatments that we have in medicine. And so there are things like stroke or ringing in your ears that have been tried with varying results. We don't treat any patients at the 32nd Street Clinic for those things. Similarly, auditory hallucinations. I've treated patients with auditory hallucinations that simply haven't responded to antipsychotic medications. Or for patients with schizophrenia who aren't leaving home, don't want to talk to other people, we might use TMS for that. A new use for TMS that's being investigated is long COVID, which has a lot of the same symptoms as major depressive disorder, like poor concentration and low energy. And there have been some surprisingly positive results treating long COVID with TMS, and it's gratifying to see. Now, there are some people who really aren't candidates for TMS, and I've included some of the reasons here that somebody wouldn't be able to get TMS. It includes having metal in your head, and so uh, that might include things like ocular eye implants or ear implants that have metal in them, metal particles in your head or neck. There's a picture here of Phineas Gage. He was an American railroad man who had a tamping iron uh, blasted through his head during a blasting accident back in the mid 1800s. It passed right through the part of the brain that I talked about, that when it's affected by a stroke can lead to depression. And Phineas Gage also had some emotional symptoms. Thankfully, though, he survived the accident, which is why he's shown here holding the tamping iron. He lived for another 12 years, and his change in personality and mood actually led him to pursue things that were very uncharacteristic of him. He became a stagecoach. He was born in New Hampshire and was working in Vermont when he had the accident, but he became a stagecoach driver in Chile, if you can imagine that, back in the 1800s. So had a very adventurous life after his accident. But you can see that affecting the part of the brain that we do apply the magnet to uh, can have deleterious or unexpected effects on people's moods and behaviors. For someone like Phineas Gage, we'd be concerned that there might be some retained metal particles in his brain, and therefore we wouldn't be able to apply a magnetic field to it. So some other magnetic items that we might be concerned about with TMS would be deep brain stimulator electrodes. Those are used for patients who might have a tremor, of Parkinson's disease. Psychiatric patients with obsessive compulsive disorder might have deep brain stimulator electrodes. And in Canada, deep brain stimulation is used for patients with depression, but not in the United States. Some patients with aneurysms might have an intracranial endovascular coil implanted, and patients who have high blood pressure or high cholesterol might have stents implanted in the vessels of their head or neck, the carotid or cerebral stents. One treatment for depression back in the mid 80s in Philadelphia and in New York, but across the country, was a vagus nerve stimulator. It's a little packet that's implanted in the chest wall, and it includes leads that run up into the neck. And because those leads are magnetic, we're not able to provide transcranial magnetic stimulation for those patients, but we definitely want to meet patients in Phoenix who have vagus nerve stimulators, because oftentimes they need to have their batteries replaced, and we're happy to check out the functioning of their stimulators and refer them to surgeons who might be able to replace their batteries. And then patients with implantable cardioverter defibrillators, we might need to turn off the cardioverter defibrillator while we do the treatment, or we might not be able to treat the patients. There are also some conditions where we are cautious about applying transcranial magnetic stimulation. And I've included asterisks after the conditions that where I've treated patients with these conditions. So you can see that it's not 100% the case that they would not be able to get treatment. So patients with seizures or who pass out, that's what syncope means, fainting. Those who have a history of head injury with loss of consciousness, which, as you might imagine, is pretty common among veterans. Interesting fact, tattoo ink might contain metal, especially colorful tattoo ink, and permanent eyeliner and makeup might contain metal. That metal can pick up the changing magnetic field and heat up, because it can induce a little electric current, and the resistance in the metal can cause the temperature of the skin to increase. So what we do in that case is we have a cold pack and we have an infrared thermometer, and we test the temperature of let's say it's the eyebrows that have permanent eyeliner or makeup on them. We'll test the eyebrows throughout the patient's treatment to make sure that it's not heating up. Or we might test the temperature of the tattoo using our infrared thermometer. And if the tattoo or the eyebrows start to get warm, we stop the treatment and apply the cold pack. Cardiac pacemakers are another device or situation in which we take extra precautions for patient safety. We coordinate with cardiologists and make sure that we're pacing those patients' pacemakers who need their pacemaker working, or we turn them off using a magnet in coordination with cardiology. Some people have implanted devices for things like sleep apnea that run through their neck, or they might have a stimulator somewhere in their head. And in those cases, we evaluate the patients on a case-by-case basis. One common question we get about TMS is whether or not it's safe to use in pregnancy. And I have treated many patients who've been pregnant because the magnetic field that's created by the magnet that we use is about 1 foot in distance. And of course, that doesn't reach all the way to the uterus from when it's placed on the head. And so TMS is safe in pregnancy. So this is a picture of the brain. And what it shows is a couple of blue ovals. One says DLPFC. That's the dorsolateral prefrontal cortex that the doctors in the neurology hospital in London told Anthony Barker about, that when a person gets a stroke there, they might get depressed. Well, we now know that there's an entire circuit in the front of the brain that works on the emotion and reward processing center. So we try to apply the magnetic field to that upper blue oval, the dorsolateral prefrontal cortex. And when we do that, when we stimulate that part of the brain, it increases dopamine transmission, which is one of the neurotransmitters that subserves happiness. And then there are some others too that are affected. GABA, glutamate, which is affected by ketamine, and serotonin, which I'm sure you've heard about. It's affected by things like Prozac and Zoloft, Lexapro, Celexa, and Paxil. I do have a protocol up there at the top of the slide, which talks about how many pulses per session a patient receives and how quickly the magnetic field changes, which is 10 times per second, and how many treatments a patient receives. So typically a patient will receive 36 treatments altogether. They'll get 30 treatments Monday through Friday, as I'll show you on a later slide. And then we taper them maybe every other day for 6 visits for a total of 36. And here's more information about what a typical treatment is like. A patient will come in on their first day, and we're a clinic, so we love our paperwork. We'll start off with consent forms and some rating scales to see what a patient's depression is like, how severe it is. And then we'll figure out where to place the magnet, where exactly that left dorsolateral prefrontal cortex is for each person. There are a few ways to do that. We use a tape measure. So we'll measure from the front of the head, right above the nose, to a bump on the back of your head where your muscles insert when you want to look up. It's called the inion. We'll put that in a computer program. It's based on a database that helps us find the left dorsolateral prefrontal cortex. So the nasient to the inion goes in on that second line that's blue. We'll measure from ear to ear. That's tragus to tragus. It's the little bump here in the front of your ear. And then we'll also measure the circumference. Those 3 measurements are compared against the database that will tell us where we want to place the magnet. The third thing we do on a first visit is to get the patient comfortable in the treatment chair. Some patients will be in the chair as long as 37 minutes per day. And so we want them to be comfortable while they're getting their treatment. The fourth step is probably the most interesting part of the visit. We determine the magnetic strength that's most likely to make someone happy. And we do that by applying the magnet to the part of the brain that makes your body move. Specifically, we apply it to the part of the brain that makes your thumb move. So we have the patient sit with their elbow at 90 degrees and their hand up in the air as if they're throwing a football. And we stimulate the contralateral or opposite side of the brain to make their thumb move. We figure out what the strength of the magnet is that makes their thumb move 50% of the time. And that's the strength of the magnet that's needed to make them happy. The last thing we do is we deliver the first treatment. There are a number of different treatments that we could deliver. We have 4 that we typically use. One is 37 minutes long. That's the longest, and it's the one that was developed first back in 2008. But there are also ones that are faster. There's a 4-minute treatment, for example, that was developed in Canada. It's called Theta Burst, and that's become a bit of a favorite in our clinic. Many patients would like to come in quickly and have their treatments done right away, and a 4-minute treatment is just the thing for them. But they all have drawbacks and benefits, and so we let the patient decide which one they like after we've described to them what treatments, what the various treatments options are. Then there's the matter of how many treatments they come in for. Daily treatments, Monday through Friday for 6 weeks, so that's 30 treatments. After 30 treatments, we begin a taper, and patients will get a total of 36 treatments. Now, nothing much happens in terms of mood until maybe about 10 or 12 treatments. By the 18th treatment, we can usually tell which patients are going to get better and which ones either are going to have a delayed response or no response at all. And that's why we do an assessment at treatment 18. When we do get to the end, 36 treatments, we have 2 ways that we assess how we did. One is safety, and that is reflected in whether the patients were able to complete their 36 treatments. There are so few side effects that about 93% of patients who start their treatment do complete it. The second metric that we use to determine if we've been successful is a rating of mood, and that's what a PHQ-9 is. Every 5 treatments, we check in with the patient to see what their depression symptoms are like, and we track their depression symptoms throughout their 36 treatments. And we look at that at the end to determine whether or not they've been successful in getting their depression into remission. So those are 2 of the things that we look for, probably the most important things that we look for in our treatment to see if we've accomplished for the patient what we set out to do. Patient access is part of making sure that our treatment is available and useful to patients. And so we have 12 consultation slots each week for new patients. We book consultations. We've been booking them within 7 calendar days. We've become a little more popular now, but we're still quite timely in how quickly we get patients in for their care. And some of the treatments we do in-house and some we do through community care, depending on what the drive time is. Not everyone can drive all the way to the 32nd Street Clinic. And if they live more than 30 minutes away, we will refer them to a community care provider closer to their home. Our patient engagement is 93% completion, as I mentioned. And we accomplish that through the methods that are listed here, including coordinating with the Veteran Resource Center that we have in our building. They do a wonderful job with making sure that we have good electronic communication through My Healthy Vet with our veterans, and that veterans are able to get reimbursed for transportation when they qualify. We also make sure that everyone knows that they have a time set aside for them each day for their treatment. And it's set, it's routine, and we use the same machine so that everyone knows what to expect before they arrive. And then we also try to introduce patients to our process and to our staff in a way that's comfortable for them. Now, some patients won't get well from TMS and some will. For those who don't, we start thinking about other interventional psychiatry procedures that might be helpful to them. And so we assume that we're going to have a 3-year relationship with everyone who starts TMS, everyone who starts interventional psychiatry. And so often the 36 treatments is not the end of the story. It's just the beginning of our time together, which leads to the last point I want to make, which is that TMS is just part of what we're offering at the Phoenix VA. And we intend to offer other treatments as well. By the end of 2023, we hope to have a nasal ketamine program at the hospital, which is where I am now. In 2024, we'd like to introduce intravenous ketamine, and the following year will be electroconvulsive therapy or shock treatment here at the hospital, which is the gold standard treatment for depression. So it's essential that we start offering that to veterans. Now, there are plenty of other interventional psychiatry modalities that veterans want to know more about and want to have available. They include things like vagus nerve stimulation, deep brain stimulation. Um, there are plenty of veterans who ask me about mushroom treatment or ecstasy. And many of those treatments are either available or will become available in the next few years. And so I want to hear from you about what you think might be helpful to you, because it will help guide us as we elaborate the rollout of services available to veterans. Feel free to send me an email. And that's what I have to say about transcranial magnetic stimulation and about interventional psychiatry generally. So I'm happy to take any questions. Let me see if I can flip over here to the computer so I can see what's in the chat.
Yeah, I've been monitoring the chat. We haven't had any come through. Maybe that's just a sign you've been doing such a great job.
I'll take it that way. Thank you.
But if anyone does have questions, you can feel free to come off mute. We've got about 6 minutes. And I think we may have some people joining from other breakouts who are getting ready for their next presentation. It looks like not. Dr. Zollo, very much appreciated your talk on treatment-resistant interventions and all the exciting things we have at Phoenix. Looks like we have one question come in from Scott. You mentioned ECT as a gold standard for depression. How does this compare with your presented magnetic treatment?
Great question. Thanks for asking that. Electroconvulsive therapy has been with us almost 100 years. And so, not surprisingly, we've optimized the delivery of electroconvulsive therapy so that for patients who have never had electroconvulsive therapy, 80 to 90% of patients will have improvement in their mood after receiving 6 to 12 treatments of electroconvulsive therapy. It's different the way it's delivered than transcranial magnetic stimulation. It's done typically 3 days a week, Monday, Wednesday, and Friday, for 2 to 4 weeks. So that works out to 6 to 12 treatments. We work with a community care partner, Banner Behavioral Health in Scottsdale, to deliver electroconvulsive therapy. And so that coordination might be on an inpatient basis for patients who have excellent transportation options. That is a responsible adult who's willing to drive them to treatment, wait around while they get the treatment, and then drive them home. They might be able to get outpatient care. And sometimes patients do both. They'll start off with inpatient electroconvulsive therapy and then end with outpatient treatment. But all in all, it works out to about 6 to 12 treatments. And it does work for 80 to 90% of people who haven't had electroconvulsive therapy before for depression.